Hi everyone, welcome to hashtag CR Arthritis at the Canadian Rheumatology Association and Arthritis Health Professions Association annual scientific meeting. I'm Maya and I am the program coordinator at Arthritis Consumer Experts and also a person who's living with rheumatoid arthritis. I am joined today by Dr. Elizabeth Hazel, who is a rheumatologist and associate professor of medicine at McGill University. Thank you so much for being on our program today, Dr. Hazel.
Thank you. It was really nice of you to invite me.
So can you start by telling us a little bit about yourself and how you are involved in rheumatology?
Oh, for sure. So I work 100% of the time with the McGill University Health Center. So I'm a professor of medicine there. And the hat that I wear there is I'm the program director. So I work with the residents who are training to be rheumatologists of the future. And the next hat that I wear is I run the young adult rheumatic disease clinic there. So kids with arthritis, when they turn 18 and they transfer to the scary world of adults, then we run a transition and then a transfer clinic for them. And then the third hat I wear, one that a lot of people don't know about, is I'm actually a consultant rheumatologist to our local rehab center. And that's a really neat place where we actually get to practice multidisciplinary care for our patients. And it's probably where I think I learn a lot from my residents, but I learn a lot from working with physiotherapists and nutritionists and occupational therapists and psychologists. I learn about how I take care of patients, and I really learn about the patients.
Right. And so yesterday, I believe it was, you led a workshop session at the CRA and AHPA meeting on disability forms. I'm wondering if you can tell us why disability forms are important and what some of the goals of your session were.
Yeah, so part of this came from my hat as program director. And the residents have to learn how to fill out government forms as part of their advocacy role. And so whenever you have to teach something, you have to learn it yourself first. And then, like I said, I'm lucky enough that working at the Lethbridge-MacKay Center to work with specialists in the area of rehab, where disability is really, really the focus, and rehabilitation, the treatment. So it's not that I'm an expert with the CMPA. I'm not a lawyer. I don't know anything about the medical legal side of things. But I thought that I would be well positioned to learn and then translate that knowledge on to my colleagues.
Definitely. And from that session, I'm wondering if you can tell us again about what some of the key factors were that you covered that rheumatologists need to consider when filling out these disability forms.
So I think the first thing there is that if a patient's asking for a disability form to be filled out, it's because they feel that they that they have a right to certain services. And the second thing is that just like in a lot of things in life, we often have to take 2 steps backwards in order to make 3 steps forward. And rehabilitation's a lot like that. So a young person who just got diagnosed with arthritis, who started on medication, you know, they're still in pain, they still have fatigue, they're still adjusting to a new period of life. It may be that they need to have reduced work hours for a short period of time in order to adapt or in order to learn the skills to manage the disease on their own. So I didn't want people to think that a patient asking for a sick leave or asking to be put on disability was a finality, or it was a reflection on their poor control of the disease. It's often that there's so much more to treating arthritis and our rheumatic diseases than just the medications. And at the center, what I've learned is that it's often the nutritionist, it's often the psychologist, it's often the self-management strategies that the occupational therapist brings out. It's often all the other things that actually help with the energy management and the fatigue that are really the things that stop our patients from participating fully in the workforce.
Mhm. I really appreciate that patient-centered approach. So then touching on what you just mentioned about the fatigue or let's say brain fog, these sort of invisible parts of the disease, which can be the most debilitating, you spoke to how some of those there's some challenges then related to providing objective evidence that's needed for disability forms when it is those sorts of unmeasurable, invisible symptoms, which can be the most debilitating. So is there anything that patients can do then to help facilitate that evidence collecting process, like symptom journals, or can patients play any role in making that easier?
So there are two different sides to this answer. The first is I think that patients need to understand a little bit better about their own fatigue. And my colleague Hazel, he really embraces this thing called the spoon theory. And the spoon theory was written by a young woman with lupus as a way to explain to her friends and family about her energy needs. And one of the things that teachers and bosses and spouses and children don't understand about our diseases is that you can wake up one morning and have a ton of energy and the next day not be able to do anything. And so it's really hard for people around to understand that. What the spoon theory does is it quantifies that. It allows people to see that you wake up with a certain number of spoons of energy in the morning. And depending on what you do, that energy is going to be used up. And the energy can be used up in physical things, like if you have to get dressed and eat breakfast and prepare the kids' lunches, or it can be used up in emotional things, like hiding the fact that you have arthritis from your friends and colleagues uses an enormous amount of energy. Or having a fight with a spouse uses an enormous amount of energy, and you pay for that. And if you go into energy deficit, then you can sometimes have a lot of trouble getting out of it. So on one hand, I think that if patients understand their own energy management strategies and they can start to recognize what their limitations are, that's the first step, because you can't communicate something you don't understand yourself. And then you're right, it's a very difficult thing to write on a government form. But I think that that's where things that you mentioned, like fatigue journaling and that kind of thing, can help explain to the doctor or the person filling out the form where it impacts the day. And it can be something as simple as saying, I've noticed that when I have a 4-day week because it's a long weekend, I manage. But if I go and I have to work on a weekend, or if I go 6 days in a row, then my pain is out of control for 2 weeks after. So I think that as much information as patients can have, the better. But again, not being a government employee or anything, sometimes there's a little bit of issues that if the things that you're describing don't fit perfectly in a government form, that it doesn't get passed, or it doesn't get interpreted the way we would want it to.
Right. Right. Yeah, I can see the challenges in that for sure. But yeah, I like how you put that, that not only then is doing that sort of tracking of one's symptoms helpful in the case of if you're trying to get disability services, but also just for our own understanding of our disease. That's definitely. And so earlier on, you mentioned that what you've loved working at the rehabilitation center is having that interdisciplinary care, because often patients with chronic diseases, will see dietitian, social worker, physiotherapist, etc. As a patient, how do we choose which one of our healthcare providers to approach regarding disability forms like this?
So I tried to get at some of that in the sort of cases at the end. And there's sometimes when the family doctor is absolutely the most important person to talk to. And that's when your symptoms, whatever they are coming from a variety of different places. It may be partly from your rheumatic disease, but you may be suffering from a mood disorder. You may also have thyroid problems. Maybe you just had a surgery or something like that. And your family doctor is going to be the one that knows the most about all your healthcare that comes from all the different places. So that's the person I would go to if that's the issue. But what I tried to make clear in my talk is that if our patients are otherwise healthy and their primary and really only limitation comes from their rheumatic disease, I think it is the rheumatologist that should be responsible for those forms. That said, there are some special kind of forms. So in Quebec, to get access to, it's called transport adapté, so a special part of the bus system that's covered, and like a taxi service if you can't take public transit. It actually has to be an occupational therapist or a physiotherapist in the community that fills out those forms, because they have to measure, can you climb upstairs? They have to actually do a physical assessment that wouldn't be done in a regular rheumatology office. So I guess the bottom line is read the form and make sure it says who should fill it out. If the question you're asking pertains to your overall health, maybe it's your family doctor. But if the question is really related to a new diagnosis of a rheumatic disease or your chronic management of that disease, and the person who knows the most about that is your rheumatologist, then I think it should be the rheumatologist.
Thank you. That's really helpful information. Is there anything else that you think a patient should know when preparing to discuss disability with their healthcare provider?
So I'll flip this question around too, and I'll say what the pet peeves are of healthcare providers. And I think that while this may seem frustrating to a patient, the worst thing is if the interview is introduced by a bunch of papers going on the doctor's desk, or the opposite. So the whole interview just seems to be finishing, and you've got a plan about medication and tests, and maybe even a referral to another professional. And the doctor's like standing, hand on the door, and then, oh, can you please fill out these 5 or 6 forms as well? So, so I think that it might be good to, as a patient, to introduce when the doctor starts asking questions near the beginning of the interview. Oh, by the way, when we have time at the end, there are some forms I'd like you to look at, but not derailing the primary cause for your appointment, which is the care overall of your health and your arthritis.
Okay, great. Yeah, and I've heard that that's from other rheumatologists that it's good practice in general for us patients to get used to saying at the beginning, these are the things I want to talk about, and then the rheumatologist can decide how to then fit that into the appointment. So,
Yeah, and that's actually very different from our approach at rehab, where we don't have patients, but we have clients. And that same thing we ask, what do you want to get out of this rehab? And then we actually structure the rehab experience around what the patient wants to get out of it. So for example, if we have someone with arthritis and let's say they weigh 300 pounds, and the things that we think would help them would be a weight loss and exercise program. But the first thing that they bring up is that their mood is what's bringing them down. Then we're definitely going to look at the psychology side of things more, because you know what, that might be the thing that's limiting their healthy eating as well. So rehab allows you to be, as you said, at the center of the decision making. And I think healthcare in general is moving more and more forward.
definitely, yeah. So now kind of switching gears here, because we are on the last day of the CRA and AHPA annual scientific meeting. What do you think has been the most exciting or important thing from this year's meeting?
So I think just scanning quickly the abstracts and the presentations, there's no doubt that COVID has played a big role in every rheumatologist's life up to this point. And there have been some great sessions on telemedicine and how we're going to, not just how we're getting through things right now, but how this is going to change the landscape of rheumatology going forward. And I really appreciated the last keynote address that looked at that. And I think we're kidding ourselves if we think everything's going to go back to the way it was, because what we've learned is that might not be the best way. And maybe we've learned some really important lessons. There may be places where telemedicine is going to save our patients that commute and that parking fee and all of those things when they didn't have to see us in person. But we've also learned the sanctity of the in-person visit and how important it is on certain occasions. So it was great sharing with all our colleagues seeing that the same struggles were across the country, and learning the little tricks that people have discovered to improve quality of life and quality of care.
Great. Well, thank you so much for sharing your key takeaways from the meeting and for talking to the subject of disability forms, because I think it's something that's super important and it's something we've never, a topic we've never covered before on this program. So thank you so much.
All right. Well, good luck to you. And I'm looking forward to your future in media as well.
Thank you. And
Take care.
thank you, everyone. Our viewers will, of course, be back with more interviews. Although the meeting is over, we're continuing to do some follow-up interviews with presenters and attendees within the next coming weeks. So stay tuned.